Next, I have the privilege of introducing a new colleague. Dr. Michelle Keller recently joined the faculty of the USC Leonard Davis School of Gerontology, having come over from Cedars-Sinai Medical Center. She's a health services researcher with training in epidemiology and qualitative research methods. Her research focuses on improving medication management in older adults and facilitating patient-clinician communication. Her current work is focused on evaluating patient-centered deprescribing for high-risk medications such as opioids, benzodiazepines, and sleep medications in older adults. Please join me in welcoming Dr. Keller, who will be speaking today about medications and risk for cognitive impairment.
Thank you so much, Freddie. It is a pleasure to be here and join you today. Very excited to see such an excited group of people who are taking their Saturday to spend some time thinking about how do we improve care for our older adults with dementia. So a couple of disclosures. I do some scientific consulting for an AI company, and I do have received funding from NIH, NIA, but we'll be talking about other things today. So we're going to be briefly talking about what are some, trying to identify potentially inappropriate medications, really diving into the issue of anticholinergic burden and how it relates to cognitive impairment and dementia care, and really thinking about, how do we promote shared decision-making in when we're talking about these medications in dementia management, and I should say really beyond dementia management. So in our patients who are don't have any sort of mild cognitive impairment or dementia, but are at risk of developing some of these conditions. So as Freddie mentioned, I'm a health services researcher. I work very closely with pharmacists, clinicians, physicians of all stripes. I'm part of the US Deprescribing network. And as Freddie mentioned, I really focus on how do we try to implement interventions to try to reduce potentially inappropriate medications. So I've been using this term quite a bit. What do we mean when we say a medication is potentially inappropriate? And this comes up when I'm talking to family members, when I'm talking to people about my research. They say, well, my doctor told me to take this, right? And I think when we think about inappropriate medications, we think about drugs where the risk-benefit balance starts to tip, right? So there's a higher risk of side effects or adverse reactions compared to the potential benefits that individual could possibly get. So, and this particularly in our older adults is related to things like changes in metabolism, right, interactions. Many of our older adults have really high levels of polypharmacy. Joseph and I were just talking about the med lists that we've seen, and I'm sure that many of you have seen of people taking 20, 25 different medications, because of people having a variety of chronic conditions. I think importantly too, one of the things that, often happens is that medications get started 20 years ago, let's say, and nobody, right, we've tried to figure out, well, what happened? What did this get, why did this person get started on this particular medication? No one knows why. A person's been taking it forever, and it's really hard to stop it. So we're going to talk a little bit later about some strategies to how to help kind of deprescribe some of these medications. So we've talked about things like polypharmacy, the risks of all of these medications acting together. I'm doing some interesting research now, trying to understand how does the presence of polypharmacy actually start to influence, for example, our microbiome? And to what extent is that leading to conditions such as frailty? As we talked about a little bit, our older adults have much higher sensitivity to the side effects of a lot of medications. We're really going to be talking about medications that have a big impact on cognitive impairment. So even individuals who actually don't have dementia, who may actually have confusion and cognitive impairment as a result of taking medications. And then of course, we all know that many of these medications, it is harder as an older adult to metabolize and actually get rid of these medications in our bodies so they stay longer. So I'll be talking kind of, quite a bit about the American Geriatrics has a whole list, and they update this every 3 to 4 years, the Beers criteria. Many of you are very likely quite aware of this. And they list a variety of different medication types. I think it's always useful to take a look at what do the latest Beers medications look like. very small print, but the important thing is you can always Google this, AGS, Beers criteria, right? So and many of us know this already, our antipsychotics, our benzodiazepines, these are medications that I spend a lot of time thinking about. Things like, the medications such as Ambien and the Z drugs, right, which people kind of tend to take thinking they're not that risky. They've heard maybe things like Xanax and some of the other drugs are more risky, but their friend takes Ambien every day, so why not? Like, they borrowed some of theirs, and before you know it, they're taking it for the next 10 years. So that's kind of where some of these things get started, and that's why it's important for us, to really stop and think and stop this kind of clinical inertia, so that we make sure that our patients end up kind of in a healthier place. So now I want to talk really about the issue of anticholinergic burden. Anticholinergic medications, they are a class of medications that really block the action of acetylcholine, this neurotransmitter that's really associated with a parasympathetic nervous system, kind of that main neurotransmitter, which is really, that cholinergic system is really associated with things like movement, with emotions, thinking. So you can imagine if you're blocking the effects of this neurotransmitter, you're going to affect a variety of these different processes. So medications, and we'll talk a little bit later, and you can, as I mentioned, I'm going to show you a variety of different ways to identify how, which medications have the highest anticholinergic burden, and most importantly, the additive effects of these medications. Medications with anticholinergic effects are used to treat a variety of things through our body. Things like depression, there's a variety of antidepressants, some the tricyclic antidepressants, some SSRIs, and our antipsychotics, things like allergies, coughs and colds, incontinence, urinary retention, and some pain medications as well. And they're very widely prescribed, as you can see. I mean, these conditions cover the entire body. These are medications that are very widely used. And as we'll talk about, the importance is, of course, one medication that's potentially inappropriate is not great. The thing that we really start to get concerned about is when we start to have this additive effect of a variety of different medications loading up, and all of a sudden that person has a really high anticholinergic burden. So to kind of, here's some of the medications that I mentioned. And as I mentioned, no need to kind of memorize these. You can always look at the AGS Beers criteria. And as I mentioned, I'll talk about some screening tools to talk about to how to identify. So why do we care about these medications? These medications have been found to increase the risk of dementia. So there was a really great, very large cohort study published in 2015 where they followed individuals who started without dementia, and they actually followed them for a mean of 7 years. And they looked at what was their anticholinergic burden. They looked at all the medications that these patients were taking, and then 7 years later, they looked to see who developed dementia. Those patients with the highest kind of anticholinergic burden had a 50% higher risk of developing dementia. So that's pretty striking. And you saw a really kind of linear effect. The more the kind of, as the burden went up, the higher the risk of developing dementia. But these medications also have issues related to mortality. They're related with fall. They're associated with fall-related hospitalizations. And they also really kind of, and now particularly in our patients with dementia, they can increase the risk of delirium. They can really reduce quality of life. So in individuals where we're already trying to, ensure that they have kind of the best cognitive health possible, they're already taking some of that away. So that's why I think it's so important to really think about these medications. So the general approach that I think about when thinking about these medications is really the 4 A's, and it's a little small on the slide, but I'll go through it. So I think of awareness, right? Thinking about, do you know your anticholinergic side effects? And I think some of these side effects are very often not confused, but thought of as, oh, this is just something older people have, when in fact it's the anticholinergic medication that's causing this. So things like, for example, confusion, dizziness, sedation, blurred vision or dry eyes, feeling hot, decreased sweating, having a dry mouth, constipation, urinary retention, and if you're like scrambling to write all these down, they are on your slide, so don't worry. Things like anxiety, behavioral problems, agitation, many of these actually could be related to the anticholinergic burden. A really good example of this is I was working with some clinical colleagues, and they were telling me about a patient who had come in. He was on, 20 plus medications. He was being seen for the progression of his mild cognitive impairment. And what was so striking is that they were saying from the first time that they saw him to like 3 or 4 months later, after deprescribing many of these medications, his cognitive scores were improving, which is not what they necessarily expected, right? I mean, because we know that mild cognitive impairment can kind of decrease your cognition, but they were actually seeing that this person was doing better. They were a lot less agitated, a lot less anxious, having a better quality of life. So important to kind of think about the additive effects. I included here a variety of different kind of choices with lower anticholinergic burden, because sometimes, a person does have, reasons to take a particular medication, and there are choices that have a lower anticholinergic burden. So a little small to see. If you want a better kind of copy of some of these slides, I'll include my email at the end. Please feel free to email me, and I can send you some of those. So how do we actually look at anticholinergic burden? There's been some great online tools where you can type in kind of like the medications that your patient is taking, and it'll calculate a burden for you. So you don't have to kind of do the math. You don't have to see. There's medications that have a higher burden, some with a lower burden. You don't have to kind of do all of that sleuthing. This one I really like, AC. It's the Aging Brain Care Calculator. acbccalc.com, and that's a kind of a way to quickly calculate those. So a variety of and there are a variety of these different scales. I think the important thing is focusing on the medications that have this, again, kind of the additive effect, and focusing on those that have like the greatest anticholinergic punch. The number 3s. So hard to see on your little screen here, but the drugs with a score of 3, those are the ones with the highest degree of anticholinergic effects. Other kind of different tools that you might consider, in treating older or managing the medications of older adults living with dementia. There's a variety of different, kind of similar to the Beers criteria, but these are really more specific. So in frail adults with limited life expectancy, this particular tool, the Stop Frail, will help kind of identify which medications are really not, gonna actually have that much benefit in the long run, right? So particularly medications which we think about to prevent certain conditions. So they have a time to benefit. It may take 3 to 4. So a perfect example is, a statin, right? It can take 2 to 3 years to see the effect of a statin. And so if with an older adult that's like a 6-month life expectancy, that may not necessarily be the best choice. There's another tool called ePrognosis, and they also include some of these, some of the ways to kind of think about how long will it take for a test, a treatment, or a medication to help your patient. And so thinking about, ways to reduce that medication load in, again, places where that risk is starting to outweigh the benefit. So I've gone through a variety of different, these are medications we should think about. This is how we can screen for them. This is how we can calculate anticholinergic burden. So now what? How do we deprescribe? These are, I think, complex conversations that take some thought. And there's been some really good research actually thinking about how do we approach these conversations in a way that patients do not feel like anybody is giving up on them, right? That we're not taking something away that could really be, that they feel like, oh, you're stopping the statin, you're just letting go, you don't care anymore, right? And so I think the focus really has to be on things like quality of life, first and foremost. Reduction of side effects. How do we make your day-to-day better? How do we make sure that you are feeling your best, your anxiety is going down, your cognition is the best it could be? And some research has been that they've found are phrases like, given your age and your other health problems, I'm really worried that you're at increased risk of side effects from this medication. This medicine has been linked to side effects such as memory, concentration, balance and falls, hospitalization, and death in older adults. This medicine is not good for you in the long run. Let's work together to slowly reduce the dose and get you off of it over time. I think this idea of trying to frame it as a trial, like we're gonna test it out, we're gonna slowly take you off this medication, see how you feel, thinking about, again, kind of making it very much a shared goal and not just saying, hey, we're stopping this, like that's it, I made this decision, and it's a one-sided situation. We've really found in working with, so when I was at Cedars-Sinai, we did a lot of work around benzodiazepines, and one of the things that we found to be actually very effective was just we mailed some brochures about the risks and benefits, mostly the risks, of benzodiazepines to patients. And I will tell you, people were very skeptical. They were like, you're gonna mail some patient education materials, everyone's gonna just throw them in the trash. We actually found that it resulted in nearly a 10% greater probability of complete benzodiazepine discontinuation. We had patients who were messaging their doctor saying, no one has ever explained the risks of these medications to me. I had no idea. And I would really like to get off of them, which we found really surprising and exciting. And so I think something as simple as just, something where they can take home and they can read it through with their families is a really kind of simple and relatively cheap approach. Where can you get these patient education pamphlets? There's a variety of different materials. If you go to deprescribing.org, they have tons of resources. They have a variety of different deprescribing algorithms. So how do you take, for example, a benzodiazepine and slowly taper it off? How about an antipsychotic? How slow should you take that taper down? They have some wonderful algorithms, and they are in the process of kind of putting together a variety of guidelines on deprescribing. We have a lot of guidelines on how to prescribe. We don't have a lot of guidelines on how to take meds off, right? So I think they're doing a fantastic job. Really, really recommend. This is all at deprescribing.org. I really recommend their resources. Here's one for benzodiazepines. Last thing I want to touch upon is how do we work with care partners to deprescribe? So I've done some research in talking to caregivers, and they, as many of you know, place an immense amount of pride in the work that they do to try to take care of that person who they're, caring for. So I think it's that same sense of, we know that you're doing the best you can. We want to try to improve that quality of life. We want to try to show that there's a lack of benefit now, and there's a variety of side effects. And I think trying to get to that place where you both say, it's not worth it anymore, right? Setting deprescribing conversations can take a while, so really setting that stage over time, contrasting the benefits and the medications with the immediate risks. So for example, let's say, as we talked about, with the time to, those medications that take time, the benefit may be way down the road for somebody, but the harm is now, right? So that's why kind of really thinking about the fact that it may take a variety of it may take several conversations before you're able to kind of get that person to buy in, or their family, and that's okay. So thinking about, as kind of to summarize, so deprescribing can take a long time. Patients and their families will need some support. Thinking about taking a trial period, maybe you're going to say, hey, we're going to try this out for a couple of months, try tapering you down. We want to make sure you don't feel any withdrawal effects. We're going to do it really slowly. Thinking about dose reductions, even if not complete discontinuations, is a win. I think there's some great evidence that just reducing the dose of many of these medications can reduce, our anticholinergic burden. And I think, many older adults might say, if you, instead of framing it as we're going to stop this medication completely, saying we're just going to lower the dose. We want you to be safe. So let's just lower the dose before we get to a place where we completely discontinue it. If you have access to a clinical pharmacist, they're amazing resources. And as I mentioned with my benzodiazepine work, I think a lot of clinicians assume, well, I mean, these medications have harms. Surely somebody, I mean, the benzodiazepines have a black box warning. But still, right, you don't assume they've heard it before. More than anything, you as a clinician are a really trusted partner in their care. They trust what you say. And so really emphasizing the harms of these medications may kind of at least plant that seed, so maybe eventually down the line they might consider deprescribing. And, I think it's really important to note that clinicians really need support as well, right? So, as clinicians, there's a lot of potential negative experiences, right? You might have brought it up once and the patient or the family reacted really badly. I really need this medication. And so it can really lead to some pessimism around deprescribing. I think of it as really analogous to smoking cessation. You just got to keep on trying, maybe the first time didn't work, maybe the fifth time is really when it works. There's also a lot, as we mentioned at the beginning, a lot of inertia, a lot of clinical inertia, and a lot of hesitancy about kind of even discussing medications from another prescriber. I think this is where engaging the patient and their family is critical, because then they can bring it up to the other patient, saying, hey, why don't you ask your other clinician, what do you think about stopping these medications? And you might be surprised, the other clinician agrees. They just thought, they thought you didn't want to change it, right? When are good times to discuss medication changes? I think annual visits, they are very busy, but there are also times where, medications are often being reconciled. Seminal events, somebody's had a fall or hospitalization, it's a time to check, hey, how's your cognitive impairment? How are you doing? How are you feeling dizzy? Are you feeling kind of wobbly? Maybe this is a good time for us to go through your meds. And as I mentioned, how quickly to taper, fantastic algorithms from deprescribing.org. So with that, I'll leave you with my email address. Please feel free to email me. I'd be more than happy to share copies of slides or access to additional resources on deprescribing. I think some of my work really now is focusing on how do we help empower patients to talk to kind of, start really thinking about their own medication burden, right? So many of these anticholinergic side effects, they may be feeling it, they may not always bring it up to the clinician, right? They may be feeling a really dry mouth, but not consider it a huge issue, and they have other things to talk about. So how do we help kind of empower patients to eventually bring up some of the medication burden to their clinicians? So lots of exciting work to do in this space, and I'm excited to kind of go forward. Thank you so much, and I was looking, Freddie, would we take questions now? Okay, wonderful. Happy to take questions, thank you. Or you can always email me as well. Yeah. Looks like we have a couple over here. Oh, thank you so much, Linda.
Okay, so I'm sitting in for everyone who's on Zoom. We were sitting with Michelle, and we're like, oh, is this your first time here? We had no idea you were a presenter, and you are so lovely. So I'm an associate clinical social worker, and I work in a subacute locked facility with older adults who are gravely disabled due to mental health diagnosis. And everything that you have said, I feel very empowered to go into the interdisciplinary team. My question is, how do I better advocate when a psychiatrist, who's the subject matter expert on medication, is not listening to my client on my caseload, who continues to say, my mouth is really dry, I used to be on this medication, why do I have to keep taking it? And I'm trying to advocate, but the psychiatrist is like, I'm not changing your meds. Love the psychiatrist, lovely person as well, but how do I better advocate? No shade on psychiatrists here, okay? I love you. Have a deep, profound respect for your discipline. But as the social worker advocating for my client, like, what would you suggest is like a good approach with trying to bring this, just everything you've shared, my mind is like, whoosh, in terms of medication and deprescribing, like, anyway, does that make sense?
Yeah,
my question?
absolutely. And
Okay.
it's so funny that you mentioned that, Linda, because on the way over, I was actually listening to a podcast by a psychiatrist who, so I will share that with you, who was talking about the fact that oftentimes, particularly in psychiatry, there's different, psychiatrists will do different trials of medication, right? So they start with this one, and they're like, that's not working, let's add this one. That's not working, let's add this one. So you end up getting like, somebody who's on like, multiple antidepressants, and you add an antipsychotic and such. And I think, so I think it could be about maybe addressing some of that burden, like to what extent is somebody taking some sort of duplicative therapy that's actually not helping the patient? I think can be, for example, as your patient's talking about side effects, thinking about to what extent are some of the conditions that they're still dealing with, they are now being caused by the medication, right? So like that prescription cascade where all of a sudden that patient is, starting to feel a variety of different conditions, and they're having to take on more medications to deal with that. So I think maybe approaching them in that way. But I will certainly share, I think there is something about, my sense is that they're focusing single-handedly on like, okay, well, listen, we've achieved stability, or we've achieved the goal that I think, and the reality is there's a variety of goals, and quality of life is a really important one too, right? So certainly I think, and helping them think about, particularly with respect to this conference, to what extent is that medication burden affecting your patient's cognitive health? I think that could be potentially something helpful too. Sure, yes. We're just gonna, sorry, back here. We're gonna, yes.
Thanks.
Please.
I have a
Sorry, I didn't see the
voice.
microphone.
That's okay. Do you see that frontline, besides social work within the clinics, but what about like CVS and the pharmacies? They're the ones interfacing with the older adults most often every month that get their scripts. But it's also an implementation and dissemination issue. And while the objective facts of the drug interactions and the peers, there's a whole lot of work to be done on how do you get this information out and make it a public health issue. And really, those pharmacists are probably your frontline people. And I just wanted to know, if you could comment more about that, because I find that fascinating.
Absolutely. There is some excellent work being done by one of my colleagues at USC, Steve Chen, who's done some great work, and he's really focused on how do we use community pharmacists, like our, CVS pharmacists or local pharmacies. They are really focused on improving hypertension and diabetes, but I think in terms of that dissemination work, I can't see why we couldn't translate that to patients with polypharmacy, where the community pharmacist will make phone calls, check in on the patient, and really address what are your side effects? I mean, who is monitoring these? Pharmacists have that incredible, both clinical knowledge, but also that view into like the list of 20 medications that someone's taking. So I agree with you. I think there's really some promise in taking it out of the, as Heather and I are always talking about, I'm like, how do we de-burden our primary care physicians who are dealing with so much? And how do we try to disseminate this through a variety of other ways? I think there's a lot of promise with our pharmacists, for sure. Yes, and I think we have a question right here.
Not a question, a response to the psychiatrist, because I am one. And it's, I think those of us have to stand up when we can respond to our colleagues who are not doing the right thing. And what is this psychiatrist not doing? What is the right thing that person is not doing? It's actually talking to the patient. That's the problem. And so I think this is, we could talk probably for a few hours about the changes in psychiatry that have been good and bad over the years. But one of them is that psychiatrists are less likely to talk to patients, especially if they have serious illness, serious mental illness, serious behavior problems, major cognitive impairment, and they're just doing a consultative kind of practice. The prescription pad. So it's the lack of talking to the patient that I think is behind the problem there. And you are the representative of the patient, and he or she won't talk to you either. So I think that's where the strategy would come in. Maybe at the break we can discuss that more. Okay. Okay.
Fantastic. And it looks like we have a question. Yes.
So I'm a family medicine physician with a geriatric background. We work in an FQHC, and some of my colleagues are here with me. I wanted to learn a little bit more. We are very fortunate we have USC GWEP with us. We do get a clinical pharmacist with us. I'd love to hear some real-world examples of how we can utilize our clinical pharmacist better.
Yeah, absolutely. I think clinical pharmacists can be amazing in actually, kind of to our point, they have more time to talk to the patient, right? So I think it can be a really, so I'm working on a study right now where we're sending our patients with like our highest risk polypharmacy and having them and seeing the clinical pharmacist. And the idea is it's a thorough medication review, trying to identify drug-related problems, medication adherence issues, drug-drug interactions. Identifying side effects, I think, is a critical issue that I think pharmacists are very good at doing. And really kind of also thinking about ways and try to simplify medication regimens. So identifying duplicative therapies, as we were saying, I think they can be, and I actually think they're also really great in pharmacists that I've worked with are amazing at talking to patients. Patients feel very at ease. They can ask maybe many of the questions where they may not have always asked the physician, because they're like, I don't know if my doctor cares about this, right? But they feel like they can kind of share a lot with physicians, with pharmacists. So I think if you have that opportunity to really have the clinical pharmacists meet with the patients, that's a really great way to do that. And if not, I think even just a med review, right, of like having them look at like the anticholinergic burden and saying, what are alternatives that you would recommend, could be really useful too. Great. I think other questions. No?
Hi, good morning. I'm a geriatrician with UCI, and I had a question about supplements and herbal, things over the counter, things that patients self-medicate. I have that a lot with my geriatric patients who want to try stay healthy and prevent comorbidities, but I always worry because I don't have the training in that. I mean, we're lucky because we have the Susan Samueli Center with integrative medicine, but a lot of my patients don't want to go, and they still seek out more natural remedies. So any resources that you would recommend for those patients?
That's a great question. I think that's something that I think so many clinicians deal with. Every time I talk to a family member, they're telling me about a new supplement that they're taking. I think an important way that I try to frame it, and that has been kind of shown in the literature, is fundamentally, what are patients doing when they're taking a supplement or an herbal remedy? They're trying to take control of their health, right? They feel like, and they're trying to do something like good for themselves. They're trying to, I think there's also perceptions about like natural is better, right? Or like it's a vitamin, like there's vitamins in cereal, so it must be good for me. What I really tried to emphasize is, as I'm speaking, you're preaching to the choir here, right? Natural is not always better. But more important than that is there's really kind of research showing that because some supplements are so unregulated, the doses can be very dangerous. There's really, I think, and I'm happy to kind of look into some resources like, there's really high potentials for liver and kidney damage. And so maybe emphasizing at least like you may think you're doing, I guess the frame is, right, I know you want to take care of yourself. I know that being healthy is really important. That's why I really want you to be careful when you take these unregulated supplements, because I don't want you to damage your liver or your kidney. I'd rather you drink some water and go take a walk, compared to that. But I think it's a huge issue. I think it's really, and the promises, the promises that the supplement makers make and that we see, we're bombarded by the incredible advertising of this like multi-billion-dollar industry. It's really hard to fight. So like I said, that's what I kind of would advise. But if I do see better resources, I will bring it to next year's conference. Yeah. Fantastic. I'm gonna repeat what was said. So it's a website. It's a resource from the Sloan Kettering Center. It's called About Herbs, and that is a good resource for. And I will take a look at it myself. Excellent. To be able to send to patients and looking at that. And it looks like we have another resource potentially here too.
We have one.
Oh,
last
another question.
Hold on a second, please. We have a question here.
Buenos días. Hola, doctora. So my question is a research question, right? Your amazing work on seeing the prescription as a modifiable risk factor for cognitive decline. My question is about your knowledge or the data saying race, ethnicity interactions, because I'm thinking about, and I don't know the literature, I'm thinking about clinical trials and the representation of our underserved communities in clinical trials. So do we know that because of the lack of representation, the interaction of those medications is worse in our communities of color? And how do we, if we know, what can we do about it?
Yeah, fantastic question. I would say that this particular research field, and many, is really has, again, not done a great job of including communities of color. So I would say in terms of interactions per se, I think we're still missing a lot of data. What I can say is that there are potentially inappropriate medications that we know tend to be prescribed more to Black and Latino patients. So for example, the antipsychotics, like we've seen kind of research, several research studies have found that antipsychotics tend to be prescribed more to some of our patients. So I think certainly more research needed in terms of the harms and how do they interact, with kind of particularly, maybe a different burden of chronic conditions or higher burden of chronic conditions. Absolutely, really good questions, and I think really very badly needed research. Great question.
My question is regarding the resources also. We talk about the herbal or supplements. What about CBD? And recently we found a lot of contamination in some of these products. Is there any source that we can go and look to inform our patients?
That's such another really good one. I think, the number of, I did a study a few years ago where we were asking clinicians, how often is CBD, THC, how much is this coming up in your practice? And everyone was like, everybody's asking about it. It comes up all the time. People are seeing it as a potentially safer alternative, right, to many medications. I think we see some of the same issues that we see with supplements, right? These are not regularly tested products. So I don't know if there's a great resource to be able to say, well, this product is particularly better. What I can say is some of the early research shows that, some CBD and THC, these medications are sedating, right? And so I think seeing them very similarly to the other sedating medications and how they're adding to a potential, they're sedating and they're psychoactive. And all of the sedating and psychoactive medications, when you combine them, tend to have some sort of, adverse effect. So I think even though we may not know the contamination aspect as well, we do know that they're going to be, they're not perfect. It's not a miracle drug or cure. But a great question. That would be amazing if some organization took up like regularly testing the CBD products and what's in them. It'd be very helpful. Great. Wonderful. Well, thank you all so much for your questions and your engagement. I really appreciate it. Thank you so much. Thank you, Freddie.